पीडीएफ शेयर करो। अच्छा नहीं नहीं छोड़, पीडीएफ इसमें शेयर करो।
I'll come. 2 minutes.
Good evening, doctor.
Good evening.
Can you share your screen, doctor, for testing purpose?
Yeah, sure. I'll share it.
Because if I look at it as Rati and your name, it is Rati.
Can you share your screen, doctor, for testing purpose?
Yeah, sure. I'll share it.
It has Rati and your name, it is Rati.
Is my screen visible?
Yes, doctor.
Is my voice clear?
Yes, doctor. Yes, doctor.
Is my voice clear?
Yes, doctor.
Is echoing right? Are we in two different platforms?
No, sir.
The 7 polls are ready, right?
Yes, doctor, we have ready with 7 polls. Hello, doctor.
Hello.
Shall we start, doctor?
Should we wait for another 2 minutes?
Sure, doctor. Shall we start, doctor?
Yeah, let's start.
Okay, doctor. Yes, doctor. We'll start.
Good evening, everybody. I welcome you all for today's case-based discussion on respiratory distress syndrome. So we have been learning ventilation in bits and pieces. We have tried to integrate it today with a case-based discussion starting from non-invasive ventilation to invasive ventilation. How do we optimize? It's going to be a case-based discussion. Can we move the slides? Yeah, can we move the slides? Yeah, today we have an excellent panelist today. So first we have Dr. Chinmaya. She is a pediatrician and neonatologist, completed her MBBS from Vijayanagar Institute of Medical Sciences, Ballari, completed her post-graduation from JGMC Davangere. She did her neonatology training from NICE Hospital, Hyderabad. And after joining a level 3 NICU, she has recently joined us for the last 1 year. So I welcome you, Chinmaya. You can switch on the video.
Hello, sir. Thank you. Thank you, sir.
Can we move the next slide? So another colleague of mine, Dr. Dinesh Kumar, is a pediatrician and neonatologist at Ovum Hospitals. So he has an experience of nearly 10 plus years, completed his graduation from Kurnool Medical College and post-graduation from Narayana Hridayalaya. He has nearly 10 plus years of experience in neonatology. I welcome you, Dinesh. I can see Dinesh and Avinash are together there. So I think you are muted there.
Thank
I
you.
welcome
Thank
you.
you, sir.
Yeah. Next slide. So Dr. Lingaraj Mulagi. So he has 8 plus years of experience, did his MBBS from JSS Mysore, completed his MD Pediatrics from KIMS Bangalore. He underwent his fellowship training from SRMC Chennai, and he has been associated with OM for the nearly 7 plus years. I welcome you, Lingaraj.
Thank you, Abhishek.
Next slide. So we have Dr. Avinash. He did his MD Pediatrics from Indira Gandhi Institute of Child Health. He did his NICU fellowship with us. Currently, he works with Cloud9 hospitals with a special interest on ventilation, quality improvement, and infection control. I welcome you, Avinash.
Thank you, sir.
Next slide. I think we launched this neonatal ventilation course on November 17th, the World Prematurity Day, and we had nearly 154 participants registering it. I can see in the platform, nearly 50% of them already completed it. Some 50% are still, who joined late are still with that course. Probably they should be able to complete in the next 1 month. So next slide.
Next slide is thank you slide, doctor.
Yeah, sure. Thank you. So let's, without further delay, let's start off with today's agenda. So hope my screen is visible.
Yes, doctor.
Yeah. So in the next couple of minutes, let's try to understand the respiratory distress syndrome, the various surfactant types, its administration, that is when to administer, how do you handle CPAP failure, how do you set invasive ventilation in case of respiratory distress syndrome. Of course, the most important, how do we optimize with the help of graphics. So it will be an interactive session with case scenarios. So for every case scenario, there'll be 1 to 2 polling from all of you. And after the polling, I think our excellent panelists will take you through what is the answer and what are their perspectives. So I think I've already welcomed our panelist. So the first case is to Lingaraj. I'll present the case. We'll have a polling. All the participants will answer, and then we'll come back to answering by Dr. Lingaraj. So we have a 30-weeker, 1.2 kg, born to mother with pregnancy-induced hypertension. A single dose of steroids was given just 12 hours prior. What we technically call partial course of steroids was given. There are no risk factors for infection. So in the last case scenarios, we have learned the importance of delivery room CPAP. I hope everybody is practicing it. This newborn was stabilized on delivery room CPAP, shifted to NICU, transport incubator. The baby was shifted with euthermia. In the NICU, as we all know, we start bubble CPAP with rule of 5 liter per minute flow, 5 PEEP, 50% FiO2. So the questions that would come to anybody's mind would be, should we administer surfactant here? So, or if I have to be more rude, this prophylactic surfactant, I would say, role of X-ray and ABG prior to doing this or administering the surfactant. So can we have the first polling? Can we have the first polling?
Yes, doctor.
Did we launch the polling?
Launching, doctor. 1 minute.
Okay, okay, sure. Yeah, the first question is on your screen. 30-weeker 1.2, it's the same question. Administer surfactant at steroid dose is inadequate. Administer surfactant for any distress below 30 weeks. Prophylactic surfactant increases morbidity. Give surfactant only if the baby requires CPAP PEEP of 5 centimeter, 40% FiO2. There's no negative marking, remember that. Feel free to answer the question. There's no negative marking. I can see only 30% of them have voted. At least we should vote 50% more than the Lok Sabha elections. Yeah, still, I could see only 50% have voted. Yeah, that's good. Last 1 minute to vote. So in our MBBS days, one of the common techniques which our seniors taught us, whichever is the longest answer you selected, I think everybody's selecting D based on the longest rule. So we need to see whether it's correct or wrong. I think another 30 seconds more. I can see still 11 people are yet to vote. Yeah, I think all 25 participants have voted it. So can we end the poll? Most of you have chosen D. Can we share the results right away? Can we share the results?
Yes, doctor.
Yeah.
Who's sharing this? You are sharing.
Correct answer is actually C. The correct answer is C. So prophylactic surfactant increases morbidity. I think 8% of you have got it right. I think we'll go back to Lingaraj to understand why is it so. Correct answer is C. Lingaraj, back to you.
Hello, good evening. I am Dr. Lingaraj. The question in the slide was it is a 32-weeker and 1.2 kg baby having a RDS. So the question is whether there is a role of a prophylactic surfactant. As you know, there are three methods. So one is prophylactic surfactant, early rescue, and late rescue. The prophylactic surfactant is before the onset of RDS only you will be giving. As soon as the birth, you will administer the surfactant. So the early rescue is you will stabilize the baby, and if the distress is more, so within 2 hours of life, if the distress is increasing, then we will give surfactant that is called as early rescue. So anything beyond that is called as late rescue surfactant therapy. So there are many studies which have shown that initially, whenever there a baby, premature baby used to happen, there used to be elective ventilation and then prophylactic surfactant used to be given. So with that practice, the studies have shown that most of the newborn babies have underwent many complications, uh, including multiple air leaks and also about chances of PDA opening, and that has led to more poor outcomes in the baby. And the main purpose of giving surfactant and all this is mainly to improve the oxygen lung recruitment. So after the practice, once we started that early delivery room CPAP, the primary purpose of lung recruitment will be done by the CPAP, the continuous positive airway pressure that will help in recruiting the lung. So hence we can avoid giving prophylactic surfactant. So the answer will be there is prophylactic surfactant causes more morbidity. So early rescue surfactant is the treatment of choice. So you wait for the baby, you stabilize the baby and start CPAP and have a clinical assessment of your RDS based on your Downey's and SAS scoring system and have a serial monitoring. If there is any increase in the scores or if there is increase in the oxygen requirement, then you decide about the giving a surfactant. So the next question, can we go? Anything you would like to add, Abhishek?
Nothing. I would again re-emphasize that. Remember, X-ray ABG is to help you if there is any CPAP failure or for a second dose, not for the first dose. And as you rightly said, there's no role of prophylactic surfactant. It has not really changed any outcomes. It can actually increase the risk of BPD, PDA opening up. So those risks will always be there. Now let's proceed with the case. The child who was in NICU had retractions, which indicated that the baby had inadequate PEEP. So we increased the PEEP to 6 centimeters. Saturations were 99%. The FaO2 we could taper to 35% gradually over 30 minutes. Now, at 45 minutes of life, the baby is requiring PEEP of 6, FaO2 of 35%. Mind you must be recollecting now the question in which you answered the D had 5 centimeter PEEP, FaO2 40%. Here it's a PEEP is 6, FaO2 35%, respiratory rate is 70 per minute, SAS score is 3. So now you must be wondering at what level should we consider surfactant? We have animal-derived surfactants. Although we have synthetic surfactants, they have not gained popularity. We use either bovine or porcine. What should be the dose must be coming through your mind before answering these questions. So let's go to the second poll. So second poll should be on your screen. The following statement about surfactant is false. 100 mg per kg of surfactant is typically administered. Porcine causes more CLD compared to CLD is chronic lung disease compared to bovine surfactant in real world data. Surfactant needs to be administered in RDS if the baby gets intubated in the delivery room. If the baby is stable on PEEP 6 and FaO2 25%, surfactant can be deferred. You can start answering the false statement. And 20% of them are very quick. What we say 20-20 rule, 20% are always quick. They've answered impulsively there. We need to see what's the right answer. It's a false statement, not a true statement. Majority are with C. Still 16 more to answer. Yeah, you have last 5 seconds to answer. There's no negative marking, you can answer them. Okay, let's end the poll. So the right answer is actually B. Porcine and bovine have almost similar results. So remember, 100 mg per kg surfactant is typically administered. Porcine bovine have almost similar efficacy. We need to administer surfactant if the distress is severe and baby gets intubated in delivery room. And we will come back when to administer surfactant. The results are on the screen. So the right answer is answered only by 22% again. Back to you, Lingaraj.
Yeah. So, as we know, the threshold for giving a surfactant is what we discussed in the previous slide. That is early surfactant, early rescue surfactant therapy. As per the Euro guidelines, so the protocol says suggest that, and also the evidence suggests that when the oxygen requirement, that is FiO2 requirement, is more than 30%, and the PEEP CPAP pressure requirement is more than 6 centimeter of water, is the threshold we should keep for surfactant administrations. So next is in the case scenario also initially there were oxygen requirement was reduced, but later after 45 minutes there was increase in the pressure requirement, and also the oxygen requirement was more. So hence that is the threshold where we have to start giving the surfactant therapy. That is called as a early rescue surfactant therapy. So next is about the types of surfactant. As you know, there are two types, mainly the animal derived and another one is the synthetic surfactants. From the animal derived in the slide, you can see the table. So one is Beractin, that is Servanta. What we commonly use is a bovine lung extract, and the another one is porcine, that is Curosurf. So that is Procactin, that is the porcine lung extract. And as Abhishek he had told that the synthetic one, that is leucinactant, that is a protein analog, not into that clinical practice. Okay. So now coming to these two, that is the bovine lung extract and the porcine lung extract. So commonly the brand which are available in India are the bovine is Servanta, and porcine availability is brand name is Curosurf. So the dosage for Servanta is about 4 ml per kg if you go by ml per kg, and Curosurf is 2.5 ml per kg. So the main component, the why we have to think is mainly the concentration of phospholipid which is available in these two lung extract is the what which matters. So in Servanta, the concentration is 25 milligram per ml. So the dosage is say remains the same. The actual dosage is 100 to 200 mg per kg. That is the actual dosage of surfactant. So based on the concentration, the dosage is different. That's all. Okay, so the Servanta we will be giving 4 ml per kg, and Curacao we will be giving 2.5 ml per kg. Okay, so As you know, the Western, the European guidelines suggest uh, this Servanta, that is bovine lung extract dosage 100 mg per kg, and porcine lung extract 200 mg per kg is what is the Western data suggest to give the surfactant. So there are very limited studies, and also there are few studies which have compared the dosage, different dosage, that is bovine extract 100 mg per kg versus this porcine lung extract 100 mg versus 200 mg of porcine lung extract surfactant. So they concluded that in 2013 that 200 mg per kg the reduces the risk of the reduces the morbidity, mortality, and other complications. So, but our Abhishek and his team has done one beautiful study, one meta-analysis. Can you go to next slide, Abhishek? So I have put that study. Yeah. So they have done a beautiful study that is comparison of that porcine versus bovine surfactant in preterm RDS. So this is the real world. What is the multi-centric collaboration? 6 centers were enrolled, and among the 6 centers, all the preterm babies which were enrolled into this less than 32 weeker, and they divided into two groups. One is less than 28 weekers and more than 28 weekers, and they analyzed all the profile, and based on that, so the study, they have concluded that, so they have not found any difference in the outcome of BPD, or there is a requirement of another dose of surfactant, either by using with porcine surfactant, that is 200 mg, compared to the bovine surfactant, that is 100 mg per kg. So only difference is about the cost. So and about the volume. So as you know that the Curacao volume requirement is very less. That is only 2.5 ml. So for babies who are less than 28 weekers and less than 1 kg, it is easy to administer just 2.5 ml compared to the Servanta, that is bovine surfactant, which is 4 ml per kg. That is the only added advantage we will get. But that porcine surfactant comes with a cost burden in our developing countries. If we consider only the cost of the surfactant, not the overall cost of the baby or the hospital stay, only if we take. So this is the actual scenario which is happening. So don't think that always porcine Curacao, the costly medicine, is better compared to the other thing. So whatever is available, it is the timing, and it is the mode of giving, and other comorbidities which are going to influence the outcome of the baby, especially in RDS. So this is very nice study. I hope this article is being shared with you all. Please go through it. This is very helpful for our clinical practice. Yeah. Now coming to this protocol. So protocol for our RDS, which we follow in our unit. So this is as per our recent evidences. So all babies who are less than 34 weeks who are having respiratory distress, once they are admitted in NICU, first priority is to take care of temperature, airway, breathing, circulation. So if the baby, and we practice delivery room CPAP. So we start CPAP either by TPs, or we have a portable machines ventilator. We will start on CPAP. So we start with 5 centimeter of water and PEEP, and then 30% of FiO2 nasal CPAP. So then we keep monitoring the SA scores every 15 to 20 minutes. So if there is any increase in the scores of more than 3, or the retractions, or if the grunt is persisting even after starting the CPAP, then we increase the PEEP to by 1 centimeter, and we will titrate the oxygen FiO2 based on the SpO2 monitor, preferably preductal. So we target saturation between 91 to 94. If when the baby is on CPAP and we are monitoring, if the PEEP we are increasing, we can go up to 8 centimeter. But once there is a oxygen requirement is more than 30%, and if the PEEP has gone more than 6 centimeter and distress scores are same or worsening, either of them, so we have to consider giving the early rescue surfactant therapy. So the most common method of administration of surfactant is Ensure. As we all know, that will avoid the mechanical ventilation and also the biotrauma from the mechanical ventilation. So Ensure stands for intubation, surfactant therapy, and extubation, and connecting back the baby to CPAP. Another method is about LISA, that is least invasive surfactant therapy, or it's also called MIST, that is minimally invasive surfactant therapy. So where instead of uh, intubation, so we will be putting a LISA, specially designed LISA catheter into the trachea, and we will administer the surfactant with ongoing CPAP. Okay, so we will not disconnect the baby from the CPAP. So that is the main difference which happens. Okay, so as you know, the dosage for the Curacell is 2.5 ml per kg, and for Servanta it is 4 ml per kg. So after giving surfactant, we need to keep monitoring. So if it is improving, then we have to titrate our PEEP and FiO2 based on our target requirement. So if the baby is less than 30 weeks, as there are chances of apnea and other things, so we will continue the CPAP. If there is more than baby is more than 30 weeks or more than 1.2 kg, efforts are good, oxygen requirement is around room air, and distress scores are very less, you can give a trial of CPAP for those babies. If the condition is static, it is not much improvement, and if the scores are persistent, then the role of this X-ray will come. That will help us to rule out any other comorbidities and also any other complications like pulmonary leaks like pneumothorax, or is there any associated congenital pneumonia or patch kind of thing, and other problems we can identify by X-ray, and also the ABG, which will help us in knowing the respiratory status. So if there is worsening, or if there is no other comorbidities like pulmonary leaks and all, please consider after 12 hours second dose of surfactant if the oxygen requirement is persistently high and scores are persistently high. So same thing again, the method remains the same. Ensure, so, and second dose of surfactant we have to give. So if there is a worsening, then it is considered as a CPAP failure. So at that time we have to do again dope. We have to rule out and by X-ray and blood gases. And if there is a worsening, better to ventilate and start mechanical ventilation and give the second dose of surfactant. So the main purpose of X-ray is mainly to rule out, not to diagnose RDS, but to rule out other things like mainly the pulmonary leaks and collapse. Okay. So as you know, the most of the guidelines, the decision to give surfactant is solely based on your clinical findings, SAS scoring, plus oxygen requirement and the PEEP requirement on the CPAP. So don't wait for the X-ray for first dose, but for second dose, definitely please rule out the collapse or the other air leaks, and then consider the second dose of surfactant.
Ingraj, there is an interesting question by one of the participant asking, you have said
Yeah.
you can go up to 8 centimeter PEEP, as in I think you must be telling as per coin trial or Von DRM trial. So they're asking, in term babies, can we go up to 8 centimeter on CPAP?
The indication for starting a CPAP in term baby is different compared to the preterm babies. Okay, so generally in the the maturations would have happened there. So the etiology of RDS we have to find out in a term baby. The approach to a case of term RDS is different. So now coming to about the CPAP score going up to 8, generally in real practice, no, I don't go up to 8. So preferably I restrict to 6 to 7 max. And we have to have a very close watch on the baby as there are high risk of air leaks.
Yeah, I agree with Lingaraj. See, remember in a term baby, having a surfactant deficiency is quite rare, unless
Yeah.
it's because which we see once a year. Most common indication of CPAP in a term baby will be either a transient tachypnea of newborn or a meconium aspiration, where we tend to give PEEP not more than 6, unless there is underinflation on a X-ray. You can go up to PEEP 8 if there is ARDS or a bad pneumonia, but you need to be watchful for pneumothorax there. So to summarize, remember RDS, if it is there, the primary therapy is CPAP. try to recruit the lungs. So if you're unable to recruit the lungs with a PEEP of 6, 7 centimeter, or even up to 8 in some units, then probably you'll have to open up the lungs by giving a surfactant. Surfactant is an adjuvant to CPAP there, not a primary mode. Never focus on surfactant. Try to recruit the lungs with CPAP there. So I thank Lingaraj. So any questions you can post, we'll come back again. So at the end of it, so we'll continue with the same case. Back to Chinmaya. I think Chinmaya can switch on your video. The
Thank you,
same
Abhishek.
child. Thank you, Lingaraj. So now the child is post surfactant as the PEEP requirement was more than 6, FAO to 35%. We have given surfactant. Now the baby continues with respiratory distress. We have gone upon PEEP of 6, 60% FiO2. I think Lingaraj was mentioning about SAS score. The SAS score has gone up to 6 here. We have decided to increase the PEEP to 7. We have done a blood gas. So the blood gas shows pH of 7.18, PaO2 48, there's hypoxia, PCO2 68, acidosis. Bicarb is normal, so thereby there is respiratory acidosis. How will you proceed? Before that, let's go to the pole 3. Same child, PEEP 6 FaO2 has worsening distress. The same case. What will we do? Should we switch to HFNC? Should we intubate and take to SIMV mode? Should we administer second dose of surfactant? Rule out pneumothorax, get X-ray, blood gas, consider NIMV. You can see 1/3 of them have already answered. There's no negative marking you can answer. Everybody is preferring the longest answer. The 14 to answer. Last 30 seconds. Last 10 seconds. While people are yet to answer, I think they've decided not to answer. You can answer, there's no negative marking. The right answer is rule out pneumothorax, get X-ray, blood gas, consider NIMV. So back to you, Chinmaya.
Hi, good evening, everyone. I'm Dr. Chinmaya. So, actually, based on this question, actually, my job is very easy. Post Lingaraj sir's talk, they've clearly showed that RDS protocol and they have told what all to do next. So, in this case, the distress has worsened, and also we have done a blood gas, and all of you have answered correctly, also, like most of them. That initially, we will get an X-ray because we will be thinking the differential diagnosis of worsening of the RDS, or there can be because of the pneumothorax air leak, or it can be pneumonia also. And at last, we can think of other anomalies like malformations or any like heart diseases. So these are the conditions I look as a differential diagnosis in this particular case. And then investigation. Shall I go with the next question, sir? Investigations and all?
Yeah, you can proceed.
So, how do we investigate or diagnose? So, it's already been explained this point also. Like, we'll go for an X-ray, and bedside we can always do the transillumination test to look for the air leaks and all. And in the X-ray, we'll come to know the worsening of the RDS or it is a pneumonia. We'll have some idea regarding that. And when do we call a CPAP failure? If the baby is on maximum settings of the CPAP, that is PEEP of 7, usually as told, clinically we won't go up to 8 centimeter of PEEP. So when the baby is on 7 centimeter of PEEP and FO2 requirement is already more than 60%, and there is an hypercarbia acidosis is there with hypoxia, and definitely we should consider it as a CPAP failure. And what is the next best modality to go for this baby? Should we intubate or not? Definitely, I will not intubate this baby because to prevent the long-term complications like BPD and also like VAP, which is ventilator-associated pneumonias. So next best modality will be the non-invasive mode of ventilation, that is NIMV. So in this scenario, I would like to go with the NIMV after ruling out the pneumothorax, pneumonias and all. And I would also like to consider the second dose of surfactant if required. Sir, anything you would like to add on?
Right. I think always try to consider non-invasive mode, that is switch to NIMV before placing a ET in there. So now at 2 hours, so we have decided to go to NIMV, ruled out pneumothorax. So the baby is now on 17/5, 30 rates, inspiratory time of 0.4 seconds, 50% FiO2. We had a blood gas on NIMV. Remember, there's nothing called right or wrong in clinical practice. Every baby will show you a different challenges. Here, from CPAP, we came to NIMV. After coming to NIMV, we have carefully monitored, did a repeat blood gas. So the blood gas says pH of 7.18, PaO2 is improved to 55, PCO2 is decreased to 55, bicarb has now fallen down, 18 minus 6, 94% here. So still there is respiratory acidosis here. What are the maximum settings we can use on NIMV? You must be wondering, should we change the settings? Again, some people said, why don't we intubate? So let me go to the polling to see what you feel. So before going further, which of the following statement about NIMV is false? NIMV as a primary mode compared to CPAP is superior in RDS. Nasal HFO is an upcoming modality. HFNC is superior to NIMV in preterms. Maximum NIMV settings is 22/7, pressures 60% FiO2, which is a false statement. Last 30 seconds, I can see half of you have already answered. Some of you feel NIV is superior to CPAP. Some feel HFNC is superior to NIMV. Maximum settings, not many are accepting it as a false statement. I think half of you have answered. Remember, it's a false statement, not a true statement. 60% of you have answered. Last 10 seconds. Okay, I'll stop the poll. So remember, if I have to rank the respiratory supports, it is nasal bronch oxygen, followed by HFNC, followed by CPAP. Then comes your NIMV. Some units are using nasal HFO, various challenges. Then comes your intubation. So CPAP is superior to HFNC. In RDS, NIMV is even more superior to CPAP. The false answer there is HFNC. So back to Chinmaya.
So basically, why we want to avoid the intubation is to avoid all kind of traumas to the lungs, that is atelectotrauma, barotrauma, volume trauma, all those traumas. So in this case, we still have a scope of going up on high pressures on NIME, non-invasive ventilator support. So the maximum settings we can keep in the NIME is we can go PEEP up to 7 and PAP of up to 22 centimeter. And we always have to check whether the set pressure is delivering or not, or if there is a leak. Before considering it as a NIMV failure and going for the intubation, we should always think that whether the set pressures are delivered or not. And rate we can start from 20 and then we can go up to 60 also. Item roughly around 0.35 to 0.45. And the gas flow will be always remaining constant, that is 8 to 10 liter per minute. So, in this case, we still have the scope of going up to maximum settings on the NIMV. And then also if the SAS score is not improving, there is an increasing to worsening of the RDS, then we can think of intubating the baby.
So there's an interesting question there. I think Lingaraj or Chinmaya, either of you can answer. So Karthik asked that if there is a localized patch or pneumonia, there's a pneumonia on the X-ray, it is a localized patch there. Probably what he meant to say is there's a consolidation. If you give surfactant, is there a possibility that surfactant can go preferentially there, or even in meconium, some part is collapsed, surfactant may or may not reach there, is his concern. So how do you want to answer that? What he meant to say is there is a consolidation. You have given surfactant with the aim to reach both the lungs. Here you're not being able to reach perfectly.
Yeah, I agree with that. I agree with that. So the surfactant will always take the path of least resistance. So, but the main purpose, even in pneumonia or the RDS, is the main lung recruitment. Okay, so that's the role of main CPAP. So if you recruit the lung properly, and in spite of that, if there is a requirement uh, of high oxygenation, then the surfactant will help. So now coming to the pneumonia or the meconium, which chemical pneumonitis or the pneumonia. So there are studies which will say that, but the surfactant therapy is not the primary mode of treatment in such scenarios. So always consider underlying treatment. If at all there is a secondary deficiency, what we call it a secondary deficiency of surfactant in case of pneumonia, or there is a because of the damage of the type 2 alveolocytes, which are the main producing cells of surfactant, and the oxygen requirement is very high, you can consider giving surfactant. But yes, the distribution will not be equal, and the main strategy should be your adequate ventilation and oxygenation. And for the improvement of oxygenation, you can consider, but that's not the primary mode of treatment.
Karthik, probably what in summary Lingaraj is trying to answer, and your question is, remember, will surfactant help in pneumonia or meconium? Yes. So unlike HMD, since it's a heterogeneous disease, the response is variable. So
Variable.
probably the answer to your question lied in your question itself. You said that it's a heterogeneous lung disease. Is the response inappropriate? Yes, the response is inappropriate. So should we give? Probably as a desperate measure, sometimes we end up giving in very sick cases. Second question he has asked again to Lingaraj and Chinmay is that is atelectasis same as collapse? Or when do we say atelectasis? When do we say collapse? Because we are using both the terms similarly. Is atelectasis same as collapse?
Yeah.
See, remember, atelectasis basically is at the alveolar level. So if there is a
Yeah.
localized
So
or
the
Lingaraj.
oh, okay, okay. Sorry, sir.
Please,
So I
please,
was
please
going
go ahead,
through the
Lingaraj.
question. Yeah. So this is just a terminology's difference he is asking. So atelectasis or the collapse. Okay. So see, the moment we say collapse means it is all about the one segment of the lung is what we call. Okay, segment of the lung means it may bronchus or the this one is blocked and there is a complete collapse of that region. So we call it as collapse, as per my understanding. And then atelectasis is the at the alveolar level. So each one bronchiole will have some sets of alveoli. So in that, if there is few alveoli have opened and few alveoli have not opened, so we call that as a atelectasis. So collapse is the one where the main bronchus is blocked and the whole segment of the alveolar bronchial segment itself is closed. There is no air circulation. So that one that I can tell. And the collapse can happen even from outside pressure also, need not be always from the inside. Okay. If there is a pneumothorax, there will be mediastinal shift and there are chances of collapse. Hope I have made it little understanding.
Right. Thank you,
Chinmay,
Linga.
want to?
Chinmay, wanted to
Yeah.
add in.
So no, that's what, sir. Collapse can happen at any branching of the respiratory tree, that is at the terminal bronchioles or the respiratory bronchioles also. But mainly atelectasis means the alveolar sac will not be opened up properly. For that, surfactant is required. I mean, surface tension is not good. Surface tension will be more. That is the reason there will be atelectasis. But the collapse can happen at any branch of the respiratory bronchioles. I mean, the tree, the bronchial tree.
Right. I think both of you would have answered Karthik's question there. So let's thank you, Chinmaya, there. So let's move on to the next case. And it's over to Dinesh. So now the child is in NIMV, 3 hours of life. We have gone to maximum settings. So we have tried our best. Some people must be thinking, "Well, we should have intubated." But remember, not every case go to NIMV failure. If now on maximum settings, on NIMV failure now, we decided to intubate. Before going back to Dinesh, so I would like to launch the polling again. Yeah, the poll number 5. So if you decide to intubate this baby and connect to SIMV mode, what will be your settings pre-surfactant? Let's assume you're not given surfactant at all. What should be the initial settings? PEEP 5 centimeter, inspirator time 0.4 to 0.45, 70% oxygen, RR, you set RR of 40 per minute on the ventilator, or give a PEEP of 6, short inspirator time 0.35 seconds, FO2 70, respiratory rate 60 per minute, keep a ventilator rate of 60. Third option, let's give a very high PEEP. Already baby's on 7 PEEP on NMV. Let's give invasive PEEP of 7, short inspiratory time, FO2 40 is enough on invasive, or you decide to keep ventilator rate somewhere in between 40 to 60, that is 50. Or PEEP 5 centimeter, inspiratory time 0.4 to 0.45. Why to take risk? Why to give baby hypoxia? You decide to give 100% FiO2 and ventilate rate of 60. So it's a very challenging question there. What are the initial settings of RDS on SIMV pre-surfactant? All the 4 options have very similar values with very minor changes there. If you select one of the parameter right, then you can modify other parameters. I think 1/3 of them have answered. I don't want to give the exit poll results, but still I can see the results are not in our favor. Yeah, you can answer. No harm in attempting. You can make mistakes here, not with the baby. I think still some of you still answering. Last 10 seconds. Yeah, that's it, I think. So I'll not answer this. I'll go back to Dinesh only to help you answer this. Initial settings and should we give analgesia for intubation? Over to you, Dinesh.
Hi, good evening. I'm Dr. Dinesh. So, as babies are NIMB with high settings like PEEP 7 and FI to 70% and PAP of 22, still baby has not improved. So, we have decided for intubation. So, before intubation, so we have to consider whether to give analgesia to baby or not. So, we all know that intubation is an extreme stressful event for the baby. So it can cause bradycardia, it can cause a hypoxia for the baby, it can cause increased intracranial pressure for the baby. So normally to prevent those effects, so we give analgesia for the baby like fentanyl and morphine, and we can give atropine, which is a vagolytic, so to decrease the to prevent the bradycardia and to prevent secretions, and we can use muscle relaxant like vecuronium, so which helps us to see the airway clearly so that we can intubate very easily. So normally, we give fentanyl at the dose of 1 to 4 mics per kg. So which is given like slow push over 3 to 5 minutes. And atropine, we give 0.02 mg per kg. So the minimum dose should be 0.1 mg. It should be given before 2 to 3 minutes of intubation. And vecuronium, which is a muscle relaxant, which acts very fastly. So given at the dose of 0.1 mg per kg, that too within 2 to 3 minutes prior to the procedure. So generally, it depends on unit to unit policy. Like some units they may use all the three. Some units they use only fentanyl to prevent for the analgesia. So normally in our unit we use only analgesia for the baby instead of giving muscle relaxant and atropine. So we give fentanyl at 1 to 2 mics per kg as a bolus dose before intubation. So once intubated, so we have intubated this baby with appropriate size PT tube and connected to the ventilator. So here we have connected to the SIMV. So with settings of P 5 centimeter, FI to 70% and TA 0.4 and rates at 40 per minute. So as we can see in the poll, the majority of people have answered PEEP of 7. But as in NIV, the PEEP is, we have put the settings of 7, but in the ventilator always it's better to start with the standard settings. So depending on the lung dynamics, we can change. So we can change the settings later. So we better to start P5 and FI to 70% as same is the NIV and TA, which is a standard of 0.4 and rates 40 per minute. So PAP of 17 centimeter. So 22 is a very high. With visible chest rise, we can stop at whatever 15 to 17 centimeter depending on the baby. And definitely not higher value like 22. So 22. And so here again the question comes whether SMV mode or assist control mode or PSV mode. So here why we have choose SMV mode here, all the mandatory breaths which we have set are synchronized with the baby spontaneous effort. So all the mandatory breaths are synchronized with the baby spontaneous effort. So whatever the remaining extra spontaneous efforts, the baby they are not supported and baby has to breathe against the resistance. And definitely in SMV mode there will be expiratory asynchrony will be there. And coming to assist control mode, here all the breaths are assisted. Whatever baby is breathing, either it can be 50 or 70 or 90. So all the breaths are assisted with the spontaneous efforts. And here also in assist control mode also definitely there will be respiratory asynchrony. And so in assist control mode, suppose if the baby is breathing at 90 per minute, so then definitely it can lead to hyperventilation, and so hyperventilation will cause respiratory alkalosis and increase cerebral blood flow, which can increase the chances of IVH. So always it's initial phase better to SMV mode is always better depending on the rate. And PSV mode is it's a supportive mode. So where the patient only will control the rate, the flow time, and inspirator time, everything. So here also, if the baby has no if the baby doesn't have significant respiratory efforts, again it can lead to hypercapnia and so worsening of the lung disease. So it's better to start with the SIV mode with the standard settings of P 5 centimeter, so FI2 70, TIF 0.4 and rates 40 per minute with PAP of maximum 15 to 70. And so when to administer second dose of surfactant. So after connecting the ventilator, so we will monitor the baby. So whether we'll do a blood gas after 1 hour or we'll see the how the oxygenation happening in the baby. So if oxygenation is improving gradually, the settings we could come down. So then no need to give the second dose of surfactant. Or if the settings remain same within next 6 hours, so then better to consider for the second dose of surfactant. Or if the baby worsens in the form of like desaturation or okay, so any hypotension or sudden deterioration, then as a standard we have to evaluate for dope. Okay, so any pneumothorax, okay, any displacement of the air, so ventilator tubings, okay, so we have to do an X-ray and we have to assess. So if there is only worsening of the lung disease, so then definitely we have to consider second dose of surfactant immediately. So anything to be added, sir?
I think, thank you, Dinesh. I think he has told us the importance of analgesia because newborns also do feel pain. Handling their pain, we can actually maximize their neurodevelopment. He has told why SMV is better and when to administer. With all this, I'll open you for the next poll there. So in RDS, the preferred mode is, should we use ET-CPAP? Should we use SM with volume guarantee? Should we use assist control mode? Should we use assist control mode with volume guarantee? What is the preferred mode in RDS? I think Dinesh has answered their queries comfortably. So I can see many of them answering SMV with volume guarantee there. But still some people are fans of assist control there. Some people are fans of CPAP. They've clicked CPAP there. Last 30 seconds. 2/3 of you have answered. It's a Karnataka, like a Karnataka state government earlier. You have answers both the ways, strangely. Some people are liking SMV, some people are liking assist control. Last 10 seconds. Dinesh, do you want to address this answer? Dinesh?
So like as like I have discussed, like assist control mode, like so the babies the breathing rates are higher, so it can lead to hyperventilation. So depending on some institutes, they follow like initial stage, they better to start with assist control. Then depending on the so once the baby has improved, then you can change to other modes like PSP support and all. But like depends on unit to unit. So always like whatever comfortable, so you can start using according to your unit. So SMV, according to me, like SMV will be the better. So we can monitor and we can change according to the baby development.
So remember, when you give ET-CPAP, the resistance will be high through a narrow ET tube. Nasal CPAP is different. ET-CPAP is different. That's where rarely you would have seen infants on ET-CPAP. We always give nasal CPAP. So because the resistance is huge through a small tube, that's why ET-CPAP is out of question. As Dinesh rightly said, if you see SIMV, in SIMV, let's say I've set 40 rates. Only those 40 rates are either supported by ventilator or provided by ventilator. If the baby is breathing at 60, Other 20 is baby's own breaths. While in assist control, so the rates doesn't have any meaning there. If the baby is breathing at 60, every breath is supported, every breath. So if every breath is being supported, in the sick cases, probably it may help, it may reduce the baby's tiring out. But as the baby improves, there can be huge carbon dioxide washout, and this carbon dioxide washout can cause less cerebral blood flow and can cause PVL as well. Unless you have a continuous oxygen monitoring or frequent blood gas monitoring facility, you can avoid using assist control. But if you have, in severe cases, assist control definitely helps. In other words, assist control probably is used in severe cases. The preferred mode is SAMV with volume guarantee. So thank you, Dinesh. I don't see a chat question there. I'll go back to the last case for today. So I welcome Dr. Avinash. So Avinash, this is a 30-weeker, 1.2 kg, 6 hours of life now, already intubated, 17/5, 40 rates, inspiratory time of 0.4, FA of 35%. So before you answer this, I think I'll go for a polling. How do you assess? So the participants, you must be wondering now, we are on SIMV. Can we really assess adequacy of pressures that are delivered on real time? Can we optimize inspirator time here? Before answering these two questions by Avinash, I'll take you through the last poll of the day. Which graphic is used to optimize inspiratory time? Is it a PV loop? Is it a flow volume loop? Is it a flow time scaler? Or is it a volume time scaler? People who are new to graphics, I think you should go back today. If you have not read, listen to our graphics chapter on the GHA platform of ventilation course. Can answer it. The question is, how do you optimize inspiratory time? Should we use a loop or should we use a scaler? Anything with time is a scaler. Anything with each other is a loop. Yeah, there's no negative marking. I can see 30% of them have already completed it in the golden minute. Twenty seconds more. You can answer last 10 seconds. It's a very simple question. How do you optimize inspiratory time? Should we take help of a loop or a scaler? If loop, which loop? If scalar, which scalar? You can see majority are with C, answer C. I think I'll go back to Avinash only to make him answer this question. So back to Avinash.
As if we, when we are ventilating a newborn or a preterm, we can see the graphics. Many advanced ventilators will show the scalars and the loops. Scalars are mainly three: the flow, pressure, flow, and the volume. And in loops, we can get when we put those two scalars in a graph, we'll get the loops. And mainly here, the question was how to assess the optimize the pressures and the TI. It's an PV loop. Here, the PV loop traces changes in the pressure and corresponding changes in the volume. And the loop terminates when the patient, when the preset parameters is achieved. It may be the pressure or the loop, pressure controlled or volume controlled. And by looking at the loop, we can derive PIP as well as the delivered tidal volume in this loop. And if you look at the loop, here in the upper part, we can see there is somewhat sharpening of the loop. It's not exact. It's not the normal loop. If you divide the loops into three parts, the lower part, which causes recurrent atelectasis, and the middle part is the safer zone to ventilate the lung, and the upper part, if you see here, here, if you ventilate, and in this part there will be over distension, and over distension will lead to the barotrauma, volume trauma, which is in later stages it can lead to the BPD. By looking at the PV loop here, we can see we are giving extra PIP where there is no change in the volume which we are delivering to the baby. So we are giving extra PIP, which shows as a banana shape, or also called as penguin beak. That increase in the airway pressure without increase in the appropriate volume in the lung. Here, if you look at this loop, we should come down on the PIP or PIP, which we are giving more to the baby. The next question was the optimizing the TA. Here the RDS lung is non-compliant or poor compliance and low volume. And whatever the volume and pressure we are delivering, which is not causing much expansion because of high compliance. When we apply more TA, that is inspiratory time of more than 0.4 or 0.5, here, this is the flow scalar against the time. The positive tracing is inspiration and the negative tracing is expiration. And as soon as inspiration, the trace should go to the expiration trace. But here we see a pause. Here there is no movement of the airflow inside the lung. That means the whatever tracing is there, that is the lung inflation time, and this is the extra time what we are giving, which is not useful for the baby. It will cause inspiratory hold as well as it causes increased work of breathing. So if you see this type of scalar, this type of graph, we should reduce the TI to 0.35 seconds, which optimizes the inspiration and expiration, and baby can breathe comfortably without resisting against the ventilator. Anything
So
on
in other words, here it is actually when you have a HMD pre-surfactant, the lung compliance is less. You need more inspiratory time to open the lungs. Once you give surfactant, so the TI is not necessary. You end up having inspiratory hold. You end up reducing the TI post surfactant there. So I have two chats. I do not know to whom. So there's a question, Avinash, I think you can take it up. Which ventilator setting should not be touched or should be last to touch? Avinash. Which ventilator setting, PEEP, FiO2, PEP, TI, which one you want to touch last is probably the question there. Avinash, you want to answer? Dinesh or Lingaraj, you want to take it up? Which ventilator setting should not be touched or should be last to touch?
There's nothing like to be touched, not to be touched in the last or something. We have to understand the basic pathophysiology which is happening, and we have to know the what component of the ventilator setting is meant for what. So if you know that, you can easily use all the settings which are there for gentle ventilation of the baby. There is nothing like last to be touched, don't touch that, nothing. If the ventilator is a rescue measure, so generally, the standard way of teaching in our college days that don't touch TI and this one, don't touch the eye flow, what they say in the trigger and all, where you can set the eye flow, that is inspiratory flow to the ventilator and to the baby. But few of the ventilators does not have that option to set the eye flow and all. So uh, I generally don't manage the babies based on that kind of mindset that this has to be touched last and all. Based on the pathophysiology, blood gases, we have to decide our settings.
So I think I agree with Lingaraj. There's nothing that we should not touch or not touch. We should ideally have a continuous look at graphics. We need to train our nurses how to look at graphics and optimize each setting. I agree with Lingaraj that conventionally we are taught that never play with time, go with time. So go with the same time is what we have been taught. So I agree with Lingaraj. So ultimately we end up optimizing everything as the baby's condition improves or worsens. So the second question, if on basic ventilator setting like breathing rate of 40, the baby still has tachypnea, should we increase respiratory rate? And how much we can increase respiratory rate? I'll go back to Avinash again. Avinash? His question is, the breathing rate you have set at 40, the baby has tachypnea, so should we increase our ventilator rate?
So if you are achieving the target saturation and target tidal volume, we should not worry about the tachypnea, sir. Whatever we want the baby to be, we are doing controlled ventilation here. We want the baby to breathe with our control. Like if you have done any blood gas, if it is showing an optimal PCO2 and all, if you are increasing the respiratory rate, it will go to the assist control or PSP mode. It will be like that. We are switching to that mode if you are increasing the respiratory rate. Like how the baby is breathing more, we are giving, if you are assisting all the respiratory support, it will take us to the respiratory alkalosis or hypercapnia. If you are doing controlled ventilation, if you are achieving the saturation target and the tidal volume target, we should not be worried about the tachypnea.
Hope the answer is clear there, Karthik. So if your saturations are met, if your blood gases are fine, don't worry about tachypnea. What we are worried on a ventilator is work of breathing. If your work of breathing is still high, then probably you can go maximum till 60. Still your work of breathing is increased. Probably you may have to change the mode, SIMV to assist control or even HFO. So hope Avinash answer helped you there. His next question is about CPAP. I think I'll go back to Lingaraj on this. On CPAP, if bubbles are not coming because baby's mouth is open, can we close baby's mouth if the only reason for not coming of bubbles is opening of mouth? Also, if answer is no, then what should be done in such cases to see bubbles in CPAP? So his question
Okay.
is, baby's on CPAP with mouth open.
Mouth open. Yeah. So the basic concept of CPAP is continuous positive airway pressure. And whatever we are putting that in the underwater seal is the PEEP which is going to measure. As we know that optimal uh, bubbling is what is recommended. We don't recommend it has to bubble continuously. No, we don't recommend that. And strapping or splinting the mouth. Okay, so sometimes, and most of the time, mouth acts as a natural pressure valve release. Okay, so we don't recommend that the mouth to be strapped or it is being closed. So it acts like a natural pressure release valve. So don't try to strap that. Try to comfort the baby. So the most common reason of not bubbling will be the uh, inappropriate size of the mask. Okay, so mask or the nasal prongs if you are using. So always try to use the correct size. Okay, and strap it very neatly. Too much pain also causes too much of crying and stress. And please address the other issues also, and also find out and stabilize the head, put proper shoulder pad with adequate extension. So all these factors, it is a pure nursing care. Okay, so with that you can get good bubbling. Okay, and always don't think if bubbling is not happening, the CPAP is not being delivered. So yeah, that is one of the monitor parameter we have to say, but we should not always think that it has to bubble continuously and do this such desperate measures to close the mouth and all. Okay. So always use the adequate size of nasal mask or the prongs and head stabilization with slightly neck extension, and good nursing care can help you in getting adequate bubbling.
Yeah, thank you, Lingaraj there. I think, remember, it's stretching is good for us or the exercise, bad for the alveoli. So there's nothing positive about positive pressure. Let's
Yeah.
focus on gentle ventilation. We
Yes.
brought in here invasive ventilation because not all the times we will be able to manage with CPAP. Probably 10% of cases we may end up giving positive pressure breaths. We have started give it for shortest time and try to optimize using real time using graphics or blood gas and rarely X-ray with radiation exposure. So that's it from us, team of OVM, on this panel discussion today. So back to Global Healthcare Academy. Any questions, you can unmute yourself and ask us if you do not want to use the chat function. Hope everyone are motivated and inspired to go back and study today if you have missed any of our topics. So hope you complete them so that you apply them on the babies for the best outcomes. Back to you, back to the organizing team. So I think Karthik wants to attend offline course. I think we'll get back to you with the dates soon. I think this batch has to complete the online. Then only we'll be able to plan an offline soon. I think after this ventilation course, we are soon launching with the infection control course, which is coming up next from the next month onwards. After which I think we have many more exciting courses lined up there. So I thank everybody for joining this learning initiative. I thank GHA, I thank my colleagues, Lingaraj, Chinmaya, Dinesh, Avinash, to join despite the busy schedule and facilitating learning today. I thank you, everybody. I think Karthik, you can get back to Sumana there. So you can get back to Sumana there for the further details on offline course. Thank you, everybody. Have a happy weekend. Thank you.
Thank you, Abhijit.
Good, doctor.